the next speaker is Professor Karim Wahbi, and I must say, I realized, and to be honest, I just checked, hello, Karim, that it was in 2009 that you already went to India to help us to present for families in India and Southeast Asia in general about cardiac care. It was also World Duchenne conference. So thank you for being here again and help us to give more information about cardiac care in adult Duchenne. Thank you so much. And maybe you can also, I don't know exactly the date, but for the French-speaking people here, there is also a French conference coming soon, right? On adult care, I believe.
Yes, I think so. In about 1 month or a few weeks. Yeah. So next slide, please. So cardiac involvement in patients with DMD is mainly characterized by abnormalities of the cardiac muscle. Patients tend to develop fibrosis, which progressively replaces the normal myocardial tissue, and it can lead to the development of dilated cardiomyopathy, and unfortunately, sometimes heart failure, which represents one of the most common causes of death, mainly in adult patients with DMD. And some patients can have electrical abnormalities also, sometimes arrhythmias, sometimes ventricular arrhythmias, which can represent a cause of sudden death. But I think sudden death is far less frequent than terminal heart failure. It's a real problem, but it's less common than the development of terminal heart failure. And dilated cardiomyopathy has a prevalence which increases progressively with age, mainly after the age of 10 years and after the age of 18 years. A majority of patients have dilated cardiomyopathy, at least before the area of all the prophylactic treatments which are available now. Next slide, please. So the main things I will discuss today are, firstly, how cardiac involvement should be diagnosed and how patients should be followed, what therapeutic options are available regarding treatments, medical treatments such as heart failure medications, but also glucocorticoids, but also what indications we may have for specific cardiac devices such as cardiac defibrillators or left ventricular assist devices. Next slide, please. So the first step in cardiac management is the diagnosis, and it's very important to have a cardiac follow-up on an annual basis, mainly based on the ECG and the echocardiograms for the diagnosis of myocardial abnormalities and for their follow-up. So an annual basis is probably the minimum that should be offered to adult patients with DMD. Other examinations can be useful, particularly cardiac MRI. But one problem with cardiac MRI is the tolerance of this examination, particularly in patients who have muscular retractions or respiratory failure, particularly patients who have non-invasive ventilation. It's not always easy to make an MRI, particularly in adult patients with DMD. So MRI should be done, but for sure not on a yearly basis. We tend to arrange this examination every 5 years, but it can be perhaps every 3 to 5 years. And it's important to have an MRI to make some decisions regarding the medical treatments, but it's difficult to repeat it more frequently. Holter ECG can be useful, particularly for the diagnosis of arrhythmias, which can be sometimes asymptomatic, but it's probably mainly useful in patients who have an overt cardiac involvement, particularly in patients who have dilated cardiomyopathy with systolic dysfunction, because at early stages of the disease, it's very uncommon that we find abnormalities. Next slide, please. Then the very important point is the use of medical treatments with, on one hand, heart failure medications, and on the other hand, glucocorticoids. We have several drugs available, and many of them are initiated in prophylactic indications in patients who are still ambulant. But I think the important message is that it's never too late to initiate cardioprotective treatments, particularly ACE inhibitors. Unfortunately, there remain a significant proportion of patients who are not treated prophylactically, even at an adult age. So I think it's very important to initiate those treatments, and those treatments can be initiated quite late. And it's very important to have those treatments initiated because they have a major impact on long-term prognosis, particularly for the prevention of heart failure and terminal heart failure. Another important point is that those treatments should be up-titrated at maximal tolerated dose, because many patients have those treatments, but at a low dose. And there is an extensive literature in the general population in the field of heart failure showing that the higher doses you give, the more treatments are efficient to prevent heart failure progression. It's not always easy to up-titrate treatments patients, particularly because many adult patients have a lot of appointments. You have to see the physiotherapists, the pneumologists, the cardiologists. But sometimes it's important during just 1 year to have repeated cardiac assessments, cardiac visits, just to up-titrate the treatment, to optimize the treatment, and then you can leave the same treatment for years. And finally, we specifically discussed previously the potential effect of steroids in adult patients. And I think we have now a significant number of studies showing that steroids are beneficial at the cardiac level as well. So protection of the cardiac function is a supplemental reason for maintaining glucocorticoids. But obviously, decisions have to be made on an individual basis according to the benefit risk ratio for each patient. Next slide, please. The next point, which is extremely important and extremely difficult as well, is the prevention of sudden death. I previously mentioned that sudden death is not that common in Duchenne muscular dystrophy. At least it is obviously less frequent than in other cardiomyopathies. DMD cardiomyopathy is probably less arrhythmogenic than other cardiomyopathies. And the most important question is there a potential indication to implant a cardiac defibrillator? We have devices, several types of devices which can be used to treat ventricular tachyarrhythmias, arrhythmias in the ventricle, which can cause sudden death. Those arrhythmias can be treated with those devices. And it is generally recommended in the general populations, in patients who have particularly dilated cardiomyopathy, to implant such devices when the cardiac function is severely impaired, particularly when the ejection fraction is below 35%. And it's generally considered as a reasonable approach to implement in patients with Duchenne muscular dystrophy. But I'm not sure that it's really reasonable to offer this kind of treatment to all patients because, as I mentioned, the risk of arrhythmic events is probably lower in DMD than in other group of patients, particularly in populations where the benefit of this treatment has been validated. And on the other hand, the placement of those devices is probably associated with a greater morbidity than in other populations due to chest deformations, presence of respiratory failure. So it's probably more risky to implant an ICD in patients with DMD. So there are probably good indications, particularly the identification of ventricular tachyarrhythmias. But I'm not totally convinced, this is my personal opinion, that it should be offered to all patients systematically when the ejection fraction is below 35%. The next slide, please. And finally, the most difficult complication to manage is obviously the development of terminal heart failure. Sometimes when the cardiac function is very severely impaired, patients can present with what we call cardiogenic shock or pulmonary edema. And some patients develop those complications despite an optimal therapy. And in that case, you're in a situation where you have to treat terminal heart failure, which is extremely difficult. So in this situation, the first thing to check is whether the medical treatment has been optimized. I previously mentioned the fact that it's important to have high doses for heart failure treatments in order to obtain a maximum efficacy. And it's also important to make sure that all the treatments currently available have been initiated, because we have a large number of treatments who have proven efficacy in the general population for heart failure, at least 5-6 medications. So it's important to be proactive, to initiate those treatments, to increase the doses. But sometimes, despite that, there remains severe heart failure and with symptoms and with major impact in short term on the vital prognosis. And in that case, you will have to discuss several options. First option is the cardiac transplantation. Very few patients have been underwent cardiac transplantation worldwide. Mainly because it's extremely difficult to have a transplantation project when the respiratory function is impaired, because the risk of respiratory complications is extremely high. So it's generally considered as an option which is not reasonable, not necessarily due to the fact that the ambulation have been lost, but mainly due to the severity of respiratory involvement in a majority of cases. And an option we have now available for a few years is the implantation of left ventricular assist device. I think there are probably good indications for what we call LVADs, and there are bad indications. We have implanted in Paris 10 patients so far with quite results. This is a device which is placed by a surgeon under general anesthesia at the apex of the left ventricle. This is a kind of pump. And with this device, even when the left ventricular cardiac function is extremely low, patients can live a normal life. Some things are sometimes quite difficult to manage. Particularly, you have to check how the batteries work. You have to check that there's no infection in the place where the wire which is connected to the batteries goes out of the skin. But patients who do not have complications following the implantation, which represented the majority of cases in our centers, could live a quite normal life. And I think it's something which can be extremely interesting, but I think it's a good option for some patients, but not all. Unfortunately, it's not reasonable to plan the implantation of LVAD when the respiratory function is extremely severely impaired, and particularly in patients who have repeated pulmonary infections, because there's a risk to have an infection locally. This is also a decision which is not always easy for psychological reasons, because we have discussed this option with several patients who just refused that. They just didn't want to have such a device. So this is something which has to be discussed on an individual basis, and there can be good indications. Next slide, please. So in conclusion, the management of cardiac involvement in adult patients with DMD is very specific, really complex, and it requires great expertise, and particularly in patients who have severe heart failure. I think difficult decisions have to be made in tertiary centers. The objectives are obviously to improve prognosis, but also, and this is probably even more important, the quality of life. And it's very important to be proactive, particularly in the use of cardiac medications, and to offer all the options available to patients. But it's also important to be reasonable regarding the indications, particularly for ICDs and other cardiac devices. Thank you for your attention.